Good afternoon, good evening around the world. We're delighted to be with you with some of the world's leaders in integrating palliative care into healthcare education. And I'd like to, in the next few minutes, introduce, if I may, myself and our group and what we do. So I'm Eric Krakauer. I'm the director of the program in Global Palliative Care at Harvard Medical School in Boston, and I practice palliative care at Massachusetts General Hospital here in Boston, USA. I also am honorary chair of the Department of Ethics, Social Medicine, and Palliative Care at the University of Medicine and Pharmacy in Ho Chi Minh City, Vietnam. And in the past, I was the medical officer for palliative care at the World Health Organization in Geneva. And I always like to begin with a patient because I think that's why we're all here and why there's a consortium for universities for global health. So I have here a patient who appears to be on this in this photo in severe pain, and as far as we can tell, she's all alone. So there's a problem around the world of patients with serious illnesses, many of whom are suffering a lot, whether it's from physical pain or other symptoms, or psychological distress, or social problems such as social isolation or discrimination or extreme poverty, and spiritual distress. And there are ways to respond to this suffering, and those ways fall under the term palliative care, which has interesting translations in other languages. But palliative care is rarely accessible in low and middle income settings. And so what we're trying to do, as I'll explain, with partners around the world, is to create regional palliative care training and research centers in LMICs, low and middle income countries. And so the other photo that I'm showing here is our first, shows our faculty and our first cohort of palliative medicine specialist trainees at the University of Medicine Pharmacy in Ho Chi Minh City, which is one of our partners. I have no disclosures or conflicts of interest. So what is palliative care? Well, this is contentious, and it's still being discussed. And in a way, it's impossible to define precisely because cultural issues play a role in what palliative care should be in any one setting. But I think to generalize, palliative care is the prevention and relief of suffering of adults and children with serious health problems. Notice I did not say who are dying. It's not necessarily just for patients at the end of life. It responds to and relieves all kinds of suffering, whether physical, psychological, social, or spiritual. It improves quality of life, both of patients and their families. And it should be applied early in the course of illness, integrated with curative or disease-modifying therapies, such as chemotherapy for cancer or drug-resistant tuberculosis. And I'll just emphasize that again. It's not either disease treatment or palliative care. Palliative care should be, whenever it could be beneficial, integrated with potentially curative or disease-modifying therapies. It can promote adherence. This has been shown. Palliative care can promote adherence to disease-modifying therapies and improve outcomes. According to WHO, palliative care is an essential component of both primary care and specialized care for people with serious health problems, both during treatment and at the end of life. So who should provide it? Well, primary care doctors, specialist doctors in many different fields, not just oncology and hematology, but internal medicine, pediatrics, geriatrics, critical care, many fields, cardiology, pulmonology. It should be provided or offered or accessible in any setting, including referral hospitals, district and community hospitals, community health centers, and in patients' homes. And ideally, it's provided by an interdisciplinary or multidisciplinary team, which might include doctors, nurses, social workers, and especially community health workers can be very important. But that interdisciplinary team will not be available in every setting. In 2014, the World Health Assembly, which is the annual meeting of all ministers of health of the world, as you probably know, issued a resolution saying that PC, palliative care, is an ethical responsibility of health systems. It's not optional. It's the ethical duty of healthcare professionals to alleviate pain and suffering of any kind. It's especially important to integrate palliative care into primary care and to include home care. And efforts to minimize the risk of diversion of controlled medicines like morphine for illicit purposes must, quote, not result in inappropriate regulatory barriers to medical access to such medicines. So access to morphine in particular, which is probably the most essential of essential palliative medicines, is very limited in many places. In many places, it's just not accessible at all. Patients just suffer unnecessarily for lack of access to a safe, effective, inexpensive medicine. That resolution from the World Health Assembly also mentions 3 levels of palliative care training that I'll get back to. Basic training that should be provided for all medical and nursing students and all primary care doctors or clinical officers. Intermediate level training for all medical specialists who deal with patients with serious illnesses. So certainly oncologists, hematologists, internists, all the subspecialties of internal medicine, pulmonology, critical care, et cetera, tuberculosis. And then specialist palliative care training, not because most palliative care will ever be provided by specialists, and it doesn't need to be, and it's not something to aim for, but rather because every country needs palliative care teachers, implementers, clinical leaders, and researchers. So specialist palliative care training is needed to produce those teachers, leaders, implementers. A word about culture. There's a lot of very well-intended efforts to promote access to this somewhat, well, quote, new discipline. I think every culture has found ways to take care of the seriously ill. So it's not as if the idea of caring for the seriously ill is anything new, but there's this new term, palliative care, and well-intentioned efforts to make palliative care accessible in low and middle income countries often assume that it's just one set of practices developed in high income countries. And this sort of smacks of inadvertent ethnocentrism. The types and severity of suffering, and thus palliative care needs, vary around the world by geopolitical and socioeconomic conditions, culture, and lived experience. So in low and middle income countries with varied spectra of illnesses, people often face less healthy social conditions and less access to disease prevention and treatment. So the needs vary. For that reason, and also because in non-Western cultures, people think and make sense of the world differently, have different understandings of suffering and death and afterlife, different expectations about communication and decision-making, and different ways of caring for the seriously ill. So rather than assuming that suffering is the same everywhere and that Western palliative care applies everywhere, it's important to assess the local prevalence and severity of suffering and to have cultural humility in figuring out how to translate palliative care, and I mean both the term and the practice, into non-Western languages and cultures. This requires adaptation and sometimes recreating a term and practice that integrates scientific medicine with health promoting or salubrious local practices. And I'll just mention in anticipation of what Dr. Ningxia Hong will say, that this is the Chinese term, which after much discussion in China it was decided this will be how palliative care is translated. And I'll just say as a preamble to what Dr. Ningxiao Hong will say, that this sounds very, very different from palliative care. This is how it's termed in Chinese. What we found is that progress toward universal access to culturally adapted palliative care requires these local leaders. But clinical palliative care specialist training is rarely accessible for physicians from low and middle income countries. There are few intensive palliative care specialist training programs in low and middle income countries. And we have some of the leaders of those few countries where this is available are here with us today. And physicians from low and middle income countries are rarely able to enter palliative care specialist training programs in high income countries. So how can high quality palliative care specialist training programs be created in low and middle income countries, which is so essential for progress toward universal access to palliative care? So on that basis, we created a program in global palliative care here at Harvard Medical School. Our mission is to assist partners in low and middle income countries to establish regional palliative care training and research centers that will expedite integration of high quality pain relief and palliative care into healthcare systems and thereby improve the well-being of particularly of the global poor. And our vision is that regional palliative care training and research centers throughout the developing world will equip primary care and specialist clinicians to practice pain control and palliative care, produce leaders for the field, perform locally relevant research, and help integrate palliative care into healthcare systems. So with this today, it's my great pleasure to have some dear friends and extremely amazing colleagues, just in alphabetical order by country. From Chile, Dr. Pedro Perez Cruz from the Pontifical Catholic University of Chile. From China, Dr. Ningxiao Hong from the Peking Union Medical College Hospital. Another of our partners who's not here today, Dr. Natalie McCall and other colleagues from the University of Global Health Equity in Rwanda. We work with Dr. Kumba Gay at the University Anta Diop and the Joliot-Curie Cancer Institute in Senegal, and from Vietnam, Dr. Lê Đà Yuong from the University of Medicine Pharmacy in Ho Chi Minh City, and then a colleague with whom we worked earlier in the past, Professor Nizam from the Bangladesh Medical University. One of our first products, we only just established our program officially recently. Along with our curricula, we have various curricula, basic, intermediate, and specialist to mirror the proposal, the recommendations of WHO. We've created a clinical manual of palliative care for any setting, which is designed to be adaptable to local cultures. It's just recently published and it's open access, available online. And we worked together with contributors from around the world. Our main contributor was Dr. Rajagopal from India, but we have contributors from many disciplines and from all corners of the world. So our panel today is again Dr. Ningxiao Hong from Beijing, Dr. Lê Đà Yuong from Vietnam, Dr. Perez Cruz from Chile, and Professor Nizamuddin Ahmad from Bangladesh. So with that, I would like to ask our colleagues to introduce yourselves, and just going in order from on the agenda, Dr. Ningxiao Hong, could you please go first and introduce yourself, your home institution, and its work in palliative care? Thank you.
Okay. Thank you, Eric, and thank you Thank you for giving me this opportunity to join this virtual meeting. Dear friends, good morning and good evening. It's my great honor to join. I'm Ding Xiaohong, Director of Palliative Care Center at Peking Uni Medical College Hospital, a renowned institution with a century-long legacy of medical excellence. As a dedicated internist, I have had the privilege of accumulating 12 years of clinical experience in the Department of Medical Oncology and 8 years in the Department of Geriatrics, two fields that deeply illustrated the urgent need for holistic care beyond curative treatment. It was this profound clinical insight that fueled my passion for palliative care, a discipline dedicated to alleviating suffering and honoring the dignity of patients facing serious illness. 3 years ago, our hospital formally established the Palliative Care Center, marking a pivotal step in integrating this essential care model into China's top medical system. Our center undertakes a dual mission: nurturing the next generation of medical professionals and fostering a culture of compassionate care across the entire hospital. We are honored to deliver palliative care education to all students of Peking Uni Medical College, embedding core principles of symptom management, psychological support, and ethical communication into their medical training. Beyond the classroom, we actively engage with over 2,000 medical and nursing staffs across Peking Uni Medical College Hospital through workshops, case conferences, and peer learning sessions, and as well as our daily clinical work. Striving to shift the paradigm from treating disease to caring for the whole person, this internal advocacy has yielded tangible change. More departments now consult our team for complex patient cases, ensuring that palliative care is no longer a last resort, but an integral part of comprehensive treatment. As one of Beijing's two official hospice and palliative care guidance centers, our influence extends far beyond the hospital walls. We have taken the lead in training professionals across 9 of Beijing's administrative districts, covering half of the city, equipping over 1,000 clinicians, nurses, and social workers with evidence-based palliative care skills. These trained professionals now serve as local champions, bring quality care to communities, and bridging the gap between urban and suburban healthcare services. Nationally, our palliative care dandelion program have bloomed into a collaborative network spanning Zhejiang, Guangxi, Shanxi, and other provinces. Through on-site training, online courses, and mentorship programs, we have shared our expertise with more than 30 hospitals and care facilities, empowering them to develop their own palliative care services tailored to local needs. Our achievements thus far are deeply meaningful, but we recognize that there's much more to be done. Looking ahead, we have 3 core goals to advance palliative care in China. First, we aim to build a world-class training system in Beijing, one that combines rigorous academic curriculum with hands-on clinical practice to cultivate a steady pipeline for specialized palliative care physicians, nurses. This system will not only meet Beijing's growth demands, but also serve as a national model for standardized training. Second, we plan to expand our dandelion program to more provinces, particularly in Western China, where access to palliative care remains limited. By partnering with local health authorities and nonprofit organizations, we hope to make palliative care a universal right, not a privilege. Third, and most importantly, we aspire to establish a national palliative care specialist training based at CUGH, with the guidance and support of our esteemed senior expert in this field. This space will serve as a hub for research, innovation, and knowledge dissemination, driving the continuous development of palliative care in China. Palliative care is not about giving up. It's about giving patient and the family the best possible quality of life, even in the most challenging circumstances. Over the past 3 years, I have witnessed countless moments of comfort, connection, and dignity restored through our work. I'm deeply grateful to my team, our partners, and all those who have supported our mission. As we move forward, we remain committed to advancing palliative care with compassion, expertise, and collaboration. Together, we can build a healthcare system that truly cares for the whole person. Okay, that's what I want to say. Thank you, Eric.
Thank you, Dr. Ning. And I'll just add that Dr. Ning just this week received a very major award from the Chinese government for her tireless work. And if I may, Dr. Ning, I showed the Chinese characters that are used to translate the term palliative care. And my understanding is that these characters are very easily understood by anyone in China. They're not complicated. It's not a complicated word like palliative. And that this term emphasizes both comfort and harmony. Harmony as something that can be striven for as a goal of care. Is that correct?
Yes, it's easily to be understood. Yeah.
So my thought there is, again, going back to the cultural adaptation, that what's important in China, the Chinese palliative care will take its place along with a Rwandan palliative care, a Vietnamese palliative care, a Bangladesh palliative care. They all will be culturally adapted. And I think that we in the West can learn a lot from how palliative care is adapted for other cultures around the world. Thank you so much, Dr. Ning Xiaohong. Dr. Lei Da-Yung, you're next on our list. Would you introduce the work of your university, please?
Thank you, Dr. Eric Krakauer. I'd like to share my screen. Okay. Good morning, everyone. Thank you for the Consortium of University for Global Health and Dr. Eric Krakauer for these opportunities for me representing the team to share some of the work that we've done so far for palliative care education at the University of Medicine and Pharmacy, Ho Chi Minh City. So our journey started back in 2013. So that was the first time that Dr. Eric Krakauer with his global palliative care program came to our university, and we run annually course for a postgraduate medical doctor from various specialties, just like the recommendation of the World Health Organizations that the doctor from the field like geriatric and pediatrics need to understand palliative care, and we provide palliative care at the level of intermediate for a patient with life-limiting conditions. And our leaders recognize the importance of sustainability of the program. So that's why they advocate for the establishment of the first palliative care department in a health science university. So that requires the faculty to help master in palliative care. And in 2018, we established our first department, the first in the country. And from this department, we be able to coordinate all our educational tasks for other advancement in palliative care education. And from the department within a major health university, we were able to advocate and send a proposal to the Ministry of Health to open our first specialist training in palliative care to train leaders for palliative care in the future. That is the program recognized by the Ministry of Health in 2019. And from then, palliative care has officially recognized as a specialty in Vietnam. And now we have our own code of training and other legislation followed by the Ministry of Health. And also within that year, we established our National Society of Palliative Care called the Vietnam Palliative Healthcare Society. It's a forum for healthcare professionals and also family members and patients who are interested in advocating for palliative care in Vietnam to work as a advisor in terms of policy for the Ministry of Health and then recognize the importance of education for medical students and nursing students. In 2020, we worked with the nursing school to launch our first program of nursing basic palliative care for nursing students, for all nursing students from universities, working closely with our nursing colleague from the School of Nursing. And we ran the program of 2 weeks, 1 week of theories and 1 week clinical practice for all our nursing students. Concurrently, we also run the program for our medical students, a 2-week program rotation, which we use case-based learning to teach the key message of palliative care, including management of pain, dyspnea, breaking bad news, and discussing goals of care and the use of life-sustaining treatment. And later on, we recognize the importance of training the teams from the early stage when they were students as a team of doctors and nurses. So we launched our feasibility projects of interprofessional education for medical and nursing students in doing palliative care to provide care for patients with life-limiting conditions. It was a success. We got great accessibility from the students, but due to some structure in terms of the education of nursing and medical students are 2 different tracks. So we're still working on how to realize it in the reality. And with all this progress, we cannot do with just a team of doctors. We need that interprofessional team. And I think this is the key to our success, that we be able to build a team of all experts who are realize the importance of palliative care, including nurses, social worker, medical education expertise, and our leaders in order to be able to provide education in palliative care in Vietnam. So thank you for your attention.
Thank you, Dr. Jung. And if you could just leave that slide. Okay, too late. You took the slide down. That's okay. Thank you so much. And I just want to emphasize how remarkable the progress has been in Vietnam. I think that the University of Medicine Pharmacy in Ho Chi Minh City could be a model for how palliative care can be introduced into academic curricula. And Dr. Jung mentioned the importance of convincing the Ministry of Health, and sometimes it's also the Ministry of Education, to recognize palliative medicine as an official specialty, which was done in Vietnam, and then to create all levels of palliative care training, from basic for nursing and medical students to intermediate level for the specialist trainees. And then we're in our, 5th or 6th cohort now of specialist trainees for Vietnam, and exploring the possibility of opening that training program for the region. So there'll soon be a publication describing this remarkable progress over a very short time. So thank you so much, Dr. Jung. And maybe I also should mention, Dr. Jung is just completing his PhD in palliative care from King's College London. But this is an academic training. It's, as I mentioned at the beginning, it's very difficult. It's very rare for physicians from lower middle income countries to be able to get specialized training in high income countries, and they're not yet nearly enough specialist training programs in low and middle income countries. So this is exactly what we're trying to do and what these remarkable pioneers have been able to do. So thank you, Dr. Jung. Professor Nizam, have we sorted out the technical issues? I think you're muted. So Professor Nizam is the pioneer of palliative care in Bangladesh and anesthesiologist by training, professor at the nation's leading medical training institution, and the father of the palliative care specialist training program on which I had the privilege of collaborating some years ago. Professor Nizam, please. Well, we can't hear you. Nope.
Mr. Neza, let me see if I can message you in the chat to see if we can sort out your audio issues.
Okay, while that's going on, I really hope we all can learn from Professor Nizam. And apologies, Professor Nizam, for that problem. But let's, while we're working on that, Dr. Pedro Perez Cruz, dear friend from Chile, could you welcome, and could you tell us about yourself, your institution, and what you're doing and aiming for at your university?
Hi, Eric. Hi, everyone. It's a really great pleasure to be here and share this webinar with all these amazing colleagues from around the world. My name is Pedro Perez Cruz. I am the Palliative Medicine Section Chief at Pontificia Universidad Católica UC in Chile, Santiago. And I'm also the former chief of the Palliative Medicine Fellowship Program at my institution. I have a background in internal medicine and palliative care, and I'm also a researcher. So I'll talk a little bit more specifically about the Palliative Medicine Fellowship. This program was launched in 2018, and we now have 6 generations of graduates with 10 fellows completing the program, which are currently working in both private and public institutions across the country, which has been an amazing achievement for our group and for the country, because expanding palliative care at the specialist level, it's really, really challenging and hard. This is a 1-year fellowship program for physicians who have previously completed a residency program in internal medicine, family medicine, geriatrics, neurology, or anesthesia. And let me share with you a little bit about how we created this program. When designing this program, we followed the American and Canadian 1-year program models, which is a subspecialty model or fellowship. It's not a direct resident, it's not a primary specialty or a residency as it's known in some countries. And why we made this decision, it was because our institution had connections with the Royal College of Physicians from Canada, and we used the same competency-based framework from Canada. So that's why we decided to follow that structure in certain way that allowed us to both develop the program and also assess the quality of our program. So we were able to compare our program to other internationally recognized standards. Also, we decided to follow this pathway because clinicians at my home institution completed their training programs in palliative medicine in these countries, and therefore the 1-year training structure made sense. The other challenge that we face is that there is huge heterogeneity in the structure of palliative medicine training program at the specialty or subspecialty level in Latin America. So we were we were not able to follow a clear model from the regions, and that's why we decided to look outside the region to define the structure of our program. And before launching our palliative medicine fellowship, we worked on different goals to establish the building blocks that allowed our team to establish the fellowships. And which were these building blocks? First, we worked very hard in establishing an outstanding clinical service with provision of palliative care at different levels, including inpatient, outpatient, and at-home care services. So we worked really hard to do that, almost 10 years. We started a clinical service with 3 clinicians, 1 physician, a psychologist, and a nurse. And after 10 years, we were almost 15 people working, providing clinical work. And that's why when we decided to establish the palliative medicine program. The second building block was empowering palliative medicine clinicians as teachers and clinical preceptors. So they had to complete training in clinical education. Also, we partnered with our home institution to secure a high quality program. So we followed the standards that our institution required to establish the program. And finally, we established international partnerships that allowed our team to acquire these clinical and teaching skills. And we were able to see overseas how a palliative medicine program should look like. So after almost 7 years that after we established the program, we have achieved several milestones. So the first thing is that to highlight is this is the first and only palliative medicine fellowship in Chile. And interestingly, this is something that we did not know at the time when we established the program, is that the existence of our program allowed the Ministry of Health to recognize the specialty at the country level. So now palliative medicine is recognized in Chile as a subspecialty. Also, our program was certified by the National Accreditation Commission with an accreditation for 5 years, which is a huge recognition for our program. And the last thing that I wanted to share with you is that we are in the process now of redefining our curriculum, and we will increase the duration of the program from a 1-year to a 2-year program. And the main reason for expanding the duration of the program is the recognition that the fellows were not able to prescribe opioids comfortably after a 1-year program. This is a huge finding that we did not expect when we designed our program. And why fellows do not feel comfortable prescribing opioids? This is probably related to the lack of knowledge about palliative care and opioid prescription in undergraduate and residency graduates. So our fellows get into our program with limited knowledge about opioid prescription. So besides having to learn about how to prescribe, they need to feel comfortable prescribing opioids in high doses. As our program accepts fellows from different residency programs, we need to work during the first semester to level the knowledge of the different fellows. So those are 2 of the reasons why we're expanding the duration of our program. So the most important challenge that our academic group is currently facing is the expansion, the increase of the duration of the palliative medicine program. We'll expect that within 1 or 2 years, we will launch the new 2-year palliative medicine program. And another important thing I wanted to share with you is that one unexpected impact of the launch of our palliative medicine program is that this has allowed the field to be recognized by other specialists as recognizing palliative medicine as a defined area of knowledge. So this has also promoted the growth and recognition of the field across the country. So that's what I wanted to share.
Thank you so much, Dr. Perez-Cruz. And once again, what Dr. Perez-Cruz has done and his team in Chile at the Pontifical Catholic University is really a model, I think, for the world of how you've proceeded and succeeded in creating the leaders for the field. I have many questions for all of you, but let's see if Professor Nizam is. I wonder if you have headphones that might allow for the for audio. Are we able to access Professor Nizam's audio?
No.
No.
No, it doesn't work. Thank you
Oh,
very much. Just
now,
what?
no, now we're hearing you. We're hearing you now.
Are you hearing us?
Yes.
Are you
Yeah.
hearing me? Okay.
Yes.
All right. All right. Thank you very much. Thanks for all your patience. Eric, why don't you go ahead and me listening? I was listening you all. So, or you want me to
Would
enter?
we're ready for you if you could be so kind as to introduce yourself and your home institution's palliative care training and research achievements and goals.
Okay, thanks very much for your patience for last 40 minutes. I'm Nizam. I'm from Dhaka, Bangladesh. I was when I completed my medical school in 1979, and after 20 years of my medical school, I came to know the word palliative care. I mean the word palliative care. I never came across this word palliative care in 20 years of my medical life. Then I got a book by Robert Cross, and I'll make the long story short. And that book took me out of curiosity. It took me to South India in the Institute of Palliative Medicine, and I completed a 6 weeks basic palliative care course there. And that's all I have actually as a training program. Then I came back to the university anesthesia department where I had been working, literally somewhat obsessed with the newly found idea of palliative care. And we initiated a program in the medical university, the then only medical university, as a small rudimentary service, calling it palliative care service. And in course of time, in in third world, you can't plan anything properly, probably like Eric and others do. We just initiated a palliative care service, very small outpatient department, and the university somehow they allowed us, and gradually, I'm talking about 2007. And then in 2015, it turned into the first independent department of palliative medicine in the whole country. You can call it a cart before a horse, because when the people in general and my fellow professional colleagues didn't know or what is palliative care, there was a department of palliative medicine. And then I was put in there as a chairman of the department. And then Eric was there. We got I mean, it was me in 2007. By now, in 2015, it was us. We were a team. And then we had a chunk of money from University Grant Commission, a separate body. And then we planned for a postgraduate curriculum, probably the longest in the world. I don't know, Eric, a 5 years program for a master's in palliative medicine. And then it was approved. The curriculum was prepared by different friends, including Eric Crocker, Cynthia Go from Singapore, Suresh Kumar from India, and many others from how inside. When it became a master's post-graduation specialty, then they said that it can be an independent department. now. Then I was put as a chairman, and then I spent 2 years as a chairman, and I retired from the university. Let's not make a mistake. I am not no more the chairperson of the department in the university. But probably my real professional learning started when we organized a palliative care society of Bangladesh, and we had initiated a small program in the informal settlement, uh, which we call Coral settlement, which is the largest in the country, and palliative care program in that. We call it slum. I know it's rude in your part of the world to call it slum a slum. You call it informal settlement. We call it slum. As simple as that. The largest one. 200,000 people living there at least. And very recently, 2 weeks ago, there was a very big fire broke out in that slum, if you know about it. And the Palliative Care Society of Bangladesh is still working very actively there. Now, I will probably finish by saying only two sentences. What I learned as a chairman of the Department of Palliative Medicine on the university, I learned more when I became actively involved in that informal palliative care, the informal settlement of the slum, Coral slum. We call it compassionate Momot Coral. Actually, we call it in Bangla Momotamoy Coral, which means compassionate coral. And that has been running there since 2015 up to now. Initially it was a bit of funding from the World Hospice Palliative Care Alliance for 3 years, and gradually we took it over. We means Palliative Care Society of Bangladesh. And right now we have the most active project, Institute of Palliative Medicine in Bangladesh, and they have taken over the responsibility of the training and a little bit of very basic research thinking like that. I'll stop here, and I'll be very happy if there's any specific question regarding this. It has been a long journey, a very enjoyable journey. I say that if I'm born again, I would love to be a palliative care physician instead of being an ICU physician or anesthetist. Thank you, Eric. Thanks for including me with this very fantastic gathering. Thank you.
Thank you, Professor Nizam. You've been a great inspiration. And I would like to emphasize, well, many points, but particularly one point that Professor Nizam made, which is, I think, so important for the field, and that is that we keep our eyes and our ears attuned to the voices of suffering. And the basis for everything that we do in our program and in our partnerships is always to try to hear the voices of suffering that are usually drowned out by the cacophony of social media and especially the noise from the high-income countries. Palliative care is, if it's anything, it's about preventing and relieving suffering and to make sure that those who suffer are recognized and heard. And Professor Nizam and his students are very attentive to the suffering of the indigent sick in the Korai, a slum of 200,000 people. So thank you so much, all of you. I see we do have some questions from the colleagues joining us around the world. But if I can, before getting to those, I'd like to pose some questions for the panelists. And maybe a first one, which is very basic, is how high a priority do you think should be placed on palliative care integration into the healthcare systems of your country and of any country? And why is this such a high priority? So why do we need the teachers and the implementers? Why is palliative care integration so important? Dr. Pedro, could you maybe start with that?
Sure. Thanks for the question. I think it's a huge question. I definitely think that palliative care should be fully integrated into the health system, because the need for palliative medicine in terms of the need to relieve serious health-related suffering, it's enormous. It's just huge. And it will not possible to be faced or solved or approached if we do not have enough clinicians, nurses, psychologists, social workers, physicians who have at least some kind of knowledge to address and treat this suffering. And so that's the first part of the question, right? So how do we expand palliative care? And I think that's a question that has not been solved. We in Chile have an interesting case, because the Ministry of Health established a universal palliative care law in 2022 and allowed all the patients who require palliative care to get access to palliative care at the primary care level. So formally, all primary care clinics have the mandatory, the obligation to provide palliative care. However, the training for the clinicians is very, very little. So how do we solve that issue? Do we expand palliative care and then we take care of training? Or should we train first and then expand? I think it's a policy question that has not been clearly solved. And we in Chile are facing some of the challenges of the way this law was approved, in terms of the demand from patients has more than doubled the expected. So clinicians are not able to solve and to see all the patients who need palliative care. So I think it's a challenge, and I don't think that any country has really solved that question.
Thank you, Dr. Perez Cruz. Yeah, so around the world, we find, I think, this similar problem. There's been a lot of palliative care training that has essentially been wasted because the trainees have not been able to use what they've learned, because palliative care has not been a part of their job description, and it's not considered a standard part of primary care, although the World Health Organization says palliative care is one of the essential responsibilities of primary care, nor is it recognized as a responsibility of specialist training. And in fact, for our audience, again, around the world who's not so familiar with palliative care, I would add that I think palliative care became necessary. It had to be created as a field because of the ongoing specialization and subspecialization in modern technological medicine, where doctors are now trained to focus on one organ, like cardiologists and nephrologists, or one category of diseases like infectious disease or cancer or rheumatology, or one kind of technical skill like surgery or pathology or radiology. But who's taking care of the whole patient, especially seriously ill patients who are cared for by a lot of specialists? So palliative care, I think, among other things, it became necessary because there's a lot of suffering, but also because nobody was attending adequately to the whole patient in their social and familial context. And that's what palliative care aspires to do. And the reason I think that it's so desperately needed. So again, just to follow up on a similar question, how important do you think how important is creation of a university-based palliative care training and research center for your country? Well, let's start with for the country. So, Professor Nizam, how important was this creation of university-based palliative care training for Bangladesh?
No doubt it was important because when Nizam says something, nobody listens. When the university says something, the policymakers has a tendency to listen. Whether they listen, ultimately, that is not the issue, but at least when the university training program gets an attention. So that's one way of looking at it. It is important. But I would rather like to say a few words about that integration of palliative care with the primary health care program. I think if you ask me, I would say that that is the minimum that one can look for, integration with the primary health care. Otherwise, palliative care remains like a sort of alien specialty as a magic wand to the modern palliative medicine. Why I say that integration with the primary health care is the minimum, because the huge amount of difference that has been created across the world cannot be solved with only integration with the primary health care. It has to be integrated even with the social health science, social care, and the very minimum beginning of trying to minimize this difference is integration with the primary health care, and then proceed further more and more, trying to make as closure the difference between haves and have-nots in the society. I'm sorry if I'm being, I sound stupid, but that's exactly what I believe. As I said, that my experience in the slum, in the informal settlement, has told me that what we had been doing in the university, I won't be sarcastic that it's not needed, but I would say that integration in the primary health is much more important than opening up a university department. Thank you.
Thank you, Professor Nizam. And I think this also gets to what Dr. Perez-Cruz was saying, and we have also a question about this. How can palliative care training and practice be developed and sustained in low-income countries if governments will not integrate palliative care into national healthcare systems? Well, I think, as you were saying, Dr. Perez-Cruz, on the one hand, if training is offered, but the trainees can't practice it, the training is wasted. On the other hand, as I think we saw in Chile, and perhaps you can address this, if the government says palliative care should be accessible to all cancer patients, or palliative care should be provided in all hospitals and as part of primary care, then suddenly it's required, but there's no staff who know how to do it. So it's a question of timing. How do you get the government to require palliative care as part of standard primary care, as part of standard specialist care, but also have the staff who know how to do it, and to prepare an adequate not just a workforce, because that implies specialists, but to train all of the primary care doctors and the specialists in many fields. How do you do all that in the same time?
So I don't know if we can do it at the same time. I think we need to learn how to build momentum, So, and I think a key piece that we have not talked about is the role of civil society, like groups of doctors, groups of nurses, group of social workers who identify that this is relevant I think that that's a huge force that needs to be able to move um, um, to promote the development of palliative care. That's the case in Chile. Initially, interestingly, palliative care was started in the mid-90s by a group of anesthesiologists who were taking care of cancer patients with pain. That was the group, the anesthesiologists who were taking care of these patients, that starting building momentum and working with the Ministry of Health to say, hey, pain for cancer patients is a huge problem. And that's how palliative care started in Chile. It was not the Ministry of Health who started it. It was the civil society who decided that this was an important issue. And we had the luck that the Ministry of Health at that time was able to understand the relevance of this problem. Then in 2000, we had coverage for cancer patients for several years, and we noticed that there was a huge gap for patients with non-cancer conditions. And that's how, again, civil society and universities and different groups pushed the Ministry of Health to expand the law to provide universal palliative care law. So I think a key thing, a key skill that leaders should have is to be able to understand what are the movements that at the policy level are occurring, and how to promote palliative care in the specific context that you are working in. I think that's
Pedro, could you, you said it very quickly, there's a universal palliative care law in Chile.
Yes.
First, there was a law that said all cancer patients should have access. Now there's a law that says everyone should have access. How important was your university in making that happen?
So I think we were one of the institutions that pushed for the expansion of palliative care to become a palliative care, universal palliative care law. But what did we do? We published a paper in which we showed, using the Lancet Commission methodology, we showed what was the gap in coverage, like who were receiving palliative care, which were only cancer patients, and who were not receiving. And that was a huge issue for at the public level. So only half of the patients who needed palliative care were receiving it, and the government at that time said that their goal was to promote equity and access to everything. And we said, hey, here's an equity problem. So you need to learn how to read what's occurring in your context, and then be able to use that discussion to promote and to push our agenda. I think that's a skill that we have learned, not just myself, but the people here in our country. We have worked collaboratively with other institutions to push the agenda. So I think those are key skills that we never talk about. It's like you need to develop the programs. You need to gather data, but you need to also understand a little bit of politics.
Thank you, Professor Perez Cruz. And I know that you are also reaching out to the region, so around South America, and you're now training people, doctors and other clinicians from other countries around South America. So you're reaching this goal of being a regional palliative care training and research center. Now, China is a region unto itself. It's 1/5 or 1/6 of the world's population. It's enormous. And there are also multiple cultures there. So also question for Dr. Ning Xiaohong, how important has been the creation of your palliative medicine center at Peking Union Medical College Hospital. How important has this been, and do you think it will be for China, for the as a really a world region?
Yeah. Okay, thank you, Eric. I'm thinking about this. First, I want to say, in China, we have a large population, about 1.4 billion, and we are facing a serious aging population problem, and country's overall living standards are improved recent years, and so people's demands for quality of life have also risen. So that is the basis for our country to develop some new strategy to improve the quality of life for the whole person. And in our hospital, which is the first level general hospital in China, we the head of the CEO of our hospital thinks we have the responsibility to do some new things for the improvement of the whole health system. So it's our hospital, the first one to develop a new major of palliative care. And after this, we have developed this major for more than 10 years in our hospital. And we have been isolated a department for three years. And in this 3 years' time, we realized that the whole system, despite what the organ, we need some specialty that focus on the serious ill and focus on the suffering of the patient. So I think the work in my department, in my hospital, and as well as the work in Beijing and in some provinces in China, I have draw a lot of attention from doctors and also from the CEO of hospitals and from the government. So I think it's our time to tell more stories and also accumulate some data to tell the governments, the leaders, to realize that palliative care is important, even though we do not have specialty or subspecialty of palliative care in China. I think it's very important for us to focus all the energy to maybe persuade the key person in the government to build this specialty or subspecialty.
Thank you, Dr. Ning. And if I could just expand on that a little bit, this is my own view, is that in universities and university hospitals to influence the government to create a palliative care specialty, to require palliative care as part of other kinds of care. I think that this again leads back to the question of cultural adaptation. So again, turning to the translation into Chinese of palliative care, this calls, as I understand it, on an ancient tradition, on a very basic value in the culture of harmony. And harmony, of course, does not begin to translate this term "hua," as I understand it, in Chinese. Could you say a little bit more about the Chinese translation of the term palliative care, 缓和医疗, and how this might resonate both with patients who maybe will not fear palliative care, palliative care is sometimes a frightening term in English. And I wonder maybe this term in Chinese would not be so frightening, and how this term may this adaptation of palliative care specifically for China may also influence governments to finance palliative care training and palliative care services.
Okay. Thank you for your question. Yeah, it's I think we have spent years of time to find a better name for the translation of palliative care into Chinese. We use some I think more than 10 or 20 Chinese words to say what is palliative care. We use 呼吸治疗, we use 临终关怀, a lot of words. But those words are not so good. When people hear that it's 临终关怀, means the people is near death. They do not like this kind of words. So after years, and we began to especially those doctors from oncology department, we are thinking about how we can find a word to they not frighten patient and family. So we raised a new Chinese word, which we call it 缓和. 缓means slowly, gently. 和 harmony, not so directly connected with death. So we're thinking about to find a word that are loved by more person. So, for example, when we open our 缓和 clinic, the patient comes in and say, "Oh, 缓和 is very good. I never heard about this name." Yeah, they show their happiness when heard about this 缓和. So I think it's very important. I think in different culture, we need to find some words that are loved by people, or patients. Yeah, it's very important.
Thank you, Dr. Ning Xiaohong, and also thank you so much for staying up so late. I know it's after 10 p.m. in Beijing. Dr. Lê Da Yuan from Vietnam, could you comment on the role of your university in persuading the Ministry of Health to officially recognize palliative care as an official specialty, to approve palliative medicine specialist training program, and also if you could comment on the all-important issue of insurance, health insurance coverage for palliative care. So in what way was your university involved or influential with all of this?
Thank you, Dr. Eric, for your questions. I think your questions relating to the previous questions on the importance of having a department of palliative care within a health university, because so when we look at palliative care, we recognize it's a new specialty, but if we practice it and we see that all the principles are just good practice of medicine, so it's nothing new. It's the things that we're doing every day. So, but to tell people you should provide better care for your patient, then it might be difficult. So I think having a department with the name palliative care that draw attention from the system, so that they understand there's something new and they're curious. And also, if it's situated in a health university, it gave a sense of legitimacy to that entities. And also through the university, you will be able to have other network and be able to tap into certain pipeline, because all the university has some influential person who always plays as an advisor for the Ministry of Health. And through that pipeline and through that process, so we didn't use any kind of relations. There's certain process for you to apply to. If you want to create a new training program, you follow this structure. But if you're not in the system, you're not working in university, then you do not know all the steps that you need to follow and all the people that help you with the training program to create the training program so that you get approval from the Ministry of Health. So I think that's the importance of having a palliative care department within universities so that you can have a better chance for advocating for palliative care education and also policy. And once we have the Department of Palliative Care and we got the training, and then the Ministry of Health did a project on understanding the scope of work of all different specialties. And because they knew that we have the Department of Palliative Care within the university, so they connect with us to ask for our advice on to define the scope of palliative care for the whole nation. So I think that is the importance of having a palliative care department within the health universities.
Thank
And
you. Go ahead.
I'm sorry. And for the insurance coverage for our system, we do not code by the name of the specialty, but rather than the specific work that we've done with the patient. So through the projects of defining the scope of practice in palliative care, so we're listing all the things that we're doing for the patients, like pain assessment, giving opioid, or psychological assessment. And these things are being covered by the insurance. Once we can list all the activities or the work that we could have done for the patients. So that's how we somehow got some coverage from the health insurance, even not using the word palliative care in everything that we've done.
Thank you, Dr. Young. I'd like to focus on something you alluded to, and also Dr. Pedro Perez Cruz alluded to, which is what competencies should be required of palliative care specialist trainees. Dr. Perez Cruz, you mentioned that there's a lot of programs around the world, really, that claim to be specialist palliative care training programs. And actually, one of our research projects in our program here at Harvard is to, and actually we'll be in touch with some of you about this, is to try to develop criteria for credible, rigorous, high-quality clinical palliative care training, so that there can be a distinction between what is really a serious, high-quality palliative care specialist training program and what isn't. Some of the programs around the world are mostly or entirely online, so there's no bedside teaching. Then there are very important programs, PhD and master's programs that are academic, like the one Dr. Young is just finishing, which are very important to create the necessary research capacity. But that's not rigorous clinical training. So maybe since Dr. Young, you were speaking, could you say something about what competencies should be required? And also, if you could address something that Dr. Pedro Perez Cruz mentioned, and also Professor Nezam, some countries have only specialties. They don't have subspecialties. So for example, in the United States, if you want to do infectious disease, first you have to do internal medicine or family medicine or pediatrics, and then you do a subspecialty in infectious disease or in cardiology or in nephrology. Other countries only have specialties, so that you, right out of medical school, if you want to do cardiology, you don't first do internal medicine, you just do cardiology. So could you comment on the pros and cons of having palliative medicine as a specialty versus a subspecialty, and also on the competencies that you think are necessary to train palliative care specialists? Thanks.
Thank you for that questions. So I think for those two questions, the important thing is to understand your context I think context matter for each countries. And in our country, we initially, when we create the program, we're thinking of having for palliative care as a subspecialty, it might be a little bit better because it gave the clinician an extra layer of knowledge so that they can apply the principle on top of their original specialties so that it has more so they will then become the expert within their field. Because if you have a geriatricians have a knowledge of palliative care, then you have more impact into the geriatric community rather than a brand new palliative care physicians because you're speaking their language within that specialties. But then the Ministry of Health disagree with us because they think that every specialty should be a specialty first. And so they require palliative care as a specialty. And then if we have to more subspecialty, then we specialize in pediatric palliative care. So I think that is the depends on different contexts and also for the competency. So there are various projects on competencies for different regions and different associations like EAPC or APCA. They also have their different competency based on their context for each regions. And I think we can adapt some of the competency from similar setting to us. But the important thing is, I think, you need to buy in from stakeholders. So when you create a competency, it's not just palliative care physician working with each other, but it needs to have input from other people, other medical education, and also policymakers, so that they understand what you're doing and they have input from the very beginning, and then it becomes appropriate for your settings. Yes.
Thanks, Dr. Yun. So yeah, so in Vietnam, if I may, what we found, since actually subspecialties don't really exist yet in Vietnam, and we had asked, we had proposed to the ministry that palliative care be the first subspecialty, and there was some interesting discussion about that. But what we have, it didn't happen yet. But what has happened instead is that specialists in other fields come and do a second specialty. So, for example, we've now trained more than one pediatrician who already has specialized in pediatrics, has done essentially what we call in the U.S. a residency in pediatrics, and then they come and do our 2-year palliative medicine training program. So they're specialists in both, which is kind of similar to having a subspecialty. Specifically in Bangladesh, Professor Nizam, I remember when we were working on the palliative medicine specialist training program, there was concern about how long it was, and how it might be prohibitive if it's so long, especially if there's not a certainty that jobs will be available when they graduate. So is this still an issue in Bangladesh? How long is the program, and what are the competencies? As I recall, I remember the first year we thought would be pretty much all internal medicine, and because these are the students coming right out of medical school. What's the structure in Bangladesh and the competencies?
Yeah, what you remember is exactly what it is still now, that it has got two parts. It's called palliative residential program. It has got two parts, phase 1 and phase 2. Phase 1 is 2 years, and mostly almost all of this 24 months they rotate in the different different department of medicine, internal medicine basically. And this phase 2 is 3 years, and that is mostly in palliative medicine department, with a little bit in oncology, probably 3 months. That remains exactly there. but I will add a few things, like as you're saying about the double specialty. Similar things are happening in Bangladesh. Some of the pediatricians, for some reason, they have got a special sort of uh, aspiration to become palliative pediatrician, specialist in pediatric palliative care. Now, that is fine when you consider as an individual basis, but in a country where you have an idea, Eric, how much is the health expenditure in Bangladesh? Something around $60, and how much is in your country is about something around probably 6,000 or $15,000. Now, should we call it this double specialty or this 5 years program a wastage of national resources? Uh, that is something I quite often wonder, because the main force who is working in the informal settlement in the slum are the girls whom we call palliative care assistant, with 4 months training in the basic palliative care, with probably one doctor supervising that and one nurse supervising that. Now, you have to compare and contrast that. What about this 5 years program of MD in palliative medicine, as 13 people are still they are doing the job, but there's there haven't been a post creation in the government sector. So gradually they're getting frustrated. That means the palliative care is not properly taken into national health policy yet. There are big talks and lectures, etc., but in reality, still is we are lacking far behind. So that remains a very dilemma to me personally, to that whether this university long training is how do I explain it? How do I answer it to myself? Was it the right approach or wrong approach? Uh, yeah, I mean, I'll end there. I haven't got any answer to that yet.
Well, Professor Nizam, this is the dilemma of the pioneer. You're not following a path, you're creating a new one. And one doesn't always know if it's the best one, but there have to be the pioneers. Dr. Perez Cruz, what about this specialty versus subspecialty in Chile, and the competencies that you decided on to create again, a serious, rigorous palliative medicine clinical training program that's more than just in name?
Thank you, Eric. I think this is a huge question, and I think it's not solved. I totally agree with what Dr. Duong said, that palliative care can be different things in different contexts. So that's why the context matters. And therefore, establishing standards for palliative medicine training, I think we need to be very careful, because we need to define what's the minimum requirements. We shouldn't agree on what's the extended requirements, but what are the minimum common requirements? And it's interesting because we are in the process of redefining our curriculum, and we assessed different frameworks. We assessed the English framework, the Canadian, the Australian, the American, and they're all different. So navigating in these documents, it's extremely challenging. So we have worked really hard to trying to identify what's the minimum set of standards or skills that our clinicians should have. And I think we were able to identify some of them, but we also know that there are other skills that are required. For example, one of the things that we have noticed for our fellows and our former fellows who are currently working outside our institution is that they require a lot of skills in management, for instance. They will be leaders in their services. They have to learn how to handle groups of professionals. They need to identify goals, how to develop a program. That's a skill that's not defined in many of the internationally recognized frameworks. So I think this is a huge challenge, and that's why it's. And also, the second thing that we need to be aware of is that palliative care is a developing field. It's not static. It's not cardiology. It's not gastroenterology. It's a field that it's still developing. So I think that's a challenge for program leaders.
I'll just mention, I think that's brilliant what you just said, Pedro, the importance of teaching some management skills, leadership skills. Although I will say also, having participated in some leadership training, I think there's another field where we don't know exactly how to train people. But I think a lot of the knowledge is at business schools, but I think it's a brilliant idea and something that I hope our colleagues around the world will recognize, especially as they're working in Vietnam and in China and Africa to figure out how to create palliative care specialist training programs. That's really brilliant. Pedro, were you planning to invite faculty from business school or management? How were you planning to do that?
We have not solved it yet. As I was saying, I think there are a lot of unanswered questions, and we need to try different strategies. There's interestingly here at the School of Medicine, there's a group of clinicians working on leadership. There's a diploma in leadership. So many of the directors of the residency and fellowship programs are taking that kind of training. And also there's another piece that we have not talked about that, and I think it's another issue that it's becoming a topic here. It's the role of mentorship. Like, how do we continue supporting our fellows after they graduate? So we need to establish a really nice mentorship relationship throughout the fellowship program, and then we need to learn how to support them after, because it's challenging to be the only palliative medicine specialist in any when working alone. So I think we need to be able to support clinicians after they complete their training.
So I think these are really, really important points, Pedro. And in fact, in the training program in Vietnam, we always consider our specialist trainees, what you call fellows. We don't consider that our relationship ends when the official training ends. And in fact, I spend a fair amount of my time when I'm in Vietnam going to visit our previous trainees. I suspect that your trainees go back to hospitals around Santiago and around the country, and then they're in a situation maybe with bosses and hospital directors and provincial public health authorities who don't understand much about palliative care. So to have the leader from the top university, Pontifical Catholic University of Chile, to go and visit and shake hands with the hospital director. That I think that could be really important for palliative care nationwide, and for expansion to other universities and around the country and to hospitals. So very, very good points that I think is useful for all of us, management and follow-up of our trainees. I think that can be also fostered with research collaborations. And you know, I know we're getting to the end, but I didn't want to end without talking about research. And I very much regret that when our connection was cut off, the chat disappeared. This is why I prefer also always to get, for example, links to important documents in email rather than chat, so I don't lose them. But Pedro, while we're speaking, you know, we have this vision that I mentioned at the beginning, that we created together about regional palliative care research and training centers. And again, China is bigger than some world regions. So China is a region unto itself, and it does have a variety of cultures. But I know that you're already offering access to palliative care training to others around Latin America. And, you know, we've discussed these ideas with colleagues in Rwanda to create a palliative care, regional palliative care training and research center for Anglophone Africa, and with colleagues in Senegal to create a regional palliative care training and research center for Francophone Africa, and the same could be for Lusophone or Portuguese-speaking Africa. My question is, have you explored, Dr. Perez-Cruz, whether specialist trainees who come from other countries in Latin America, say from Peru or Ecuador or any other, Uruguay, anywhere in Spanish-speaking America, if they were to get their specialist training, if funds were available to support them to get specialist training at your institution, would that specialist training be recognized when they return? And if not, are there efforts underway to enable colleagues from other countries in your region to study, to get the specialist training from you so that they can go back to their countries and not only practice specialist palliative medicine, but create training programs in their universities?
So I think that's a huge, it's a great question and a huge challenge. So I would put the challenges in two levels. So the first challenge is that if anyone wants to come here to get training, they need to get their certification as physicians first here in Chile. So that will take some time. So that's a first barrier. And the second barrier is, as you asked, whether training here in Chile would be recognized at each country. And I think that depends on national regulations. It's it's country-based, it's country dependent. So there are countries in which any certification here in Chile might be recognized immediately. I think, for example, Bolivia. I know that's something, and Ecuador, I think that's also immediately certified, but in other countries they might need to go through a process. That's more like an administrative process rather than a clinical process. So I think those are the two main barriers. That's why we decided to develop more like an intermediate level training program in which there are no clinical skills for like properly practiced, but we use simulations or other types of training that in certain way provides some kind of clinical experience or for the development of clinical skills.
So could you say a bit more about what needs to happen for, say, a doctor from Ecuador to come to Chile to learn to enter a palliative medicine specialist training program? Is it just a question of applying for permission to be actually able to touch the patients and to take care of patients, to write orders with supervision? Is it just a question of paperwork, or do they need to take an exam, or do they need to actually spend another year doing a residency or something? What is it?
No, they need to get a certification as a physician here in Chile. So that includes a test, a theoretical exam, and also a clinical exam that you need to schedule it.
What's the clinical exam? What is that?
So it's like we call it like an internship exam, and they have to show skills in internal medicine, in pediatrics, in GYN OBG, and in surgery. So it's a one-day exam for each one of them.
One-day exam, an oral exam where they sit
it's an OSCE.
It's an OSCE. Okay, OSCE stands for
Structural Clinical Examination.
Okay. Dr. Young, we've aspired to make the specialist training available for other countries in Southeast Asia. Of course, language is an issue because so far most of our training is in Vietnamese, some in English. Are doctors, say, from Cambodia or Laos or other countries? I know we see them, I've seen them sometimes in Vietnam. Do they have to do special exams, do you know, to be allowed to get specialist training in Vietnam?
So for our students from Cambodia and Laos, sometimes we have those students, but they enroll in a very early time, at first year in medical school, and they done their training in Vietnamese, and their credentials are recognized in their home countries. But we do have regional collaborations with our colleagues from Cambodia and Laos in other projects in terms of medical educations. So it's feasible to be able to expand the program similarly.
Okay. Well, we don't want to end without talking about research. So I'm wondering about research priorities for your institution and for your countries and for your regions. So Dr. Ning, again, she's still with us very late at night, going on 11 p.m. in Beijing. Could you, again, thanks so much for staying with us. What are some of the research priorities that you see for your institution and for advancement of palliative care in China?
Yeah. Actually, we are at the beginning of our clinical things now. We are not doing so much research, but personally, I think the most important research area should be, I think it should be education research, because education is, I think, it's the fundamental step we must take first, and we need to quickly determine how to deliver education in an effective and efficient manner, so we can scale up educational initiative nationwide. And only after that we can proceed to conduct research in this education. Maybe we can begin some research such as implementation research or needs research. So I think education, research around how to do effective, efficient education is most important for us.
Thank you, Dr. Ning. And just to expand on that, in other settings, we have developed research surveys tools to study the palliative care related knowledge, attitudes, and practices of our trainees before training courses, after training courses, and then sometime later. So, for example, a year later, to see whether any improvements or any changes are sustained. And I think it's especially important, the practices, because again, as I mentioned, there's too much palliative care training that ends up with no significant benefit for patients because the trainees don't have the opportunity to practice, to implement what they've learned. So, very important to know how things are going, whether the trainees can use what they learn. Let's see, Dr. Perez Cruz, same question. Research priorities.
Yeah, again, as palliative care is dependent on the context, I think research need to be focused on what are the specific questions that need to be addressed for the development of palliative care in the country. For instance, our group has worked in trying to estimate the need of palliative care, not just currently, but for 2050. And I think that also was a huge input for the Ministry of Health to recognize how this will become a health issue. Likewise, for instance, we are now exploring the relevance of information disclosure to patients. That's something that it's very, it's promoted worldwide, and that's probably because most of the publications come from developed countries which are very oriented to autonomy. And we have found that telling our patients in certain ways increase their emotional distress. So we are trying to develop a strategy to how to provide clinical information to patients in a nice way and according to their needs, and not just assuming that the default is that they all need to have the information. So I think these two examples are trying to show that research need to be focused on the context, on what are the clinical questions that we need to solve, and what are the things that when we read the literature, the international literature, does not make sense to us. So those are the type of questions that we need to address.
Thank you, Pedro. And I just want to emphasize a few things that you just said. The research on needs, we want to be sure we're addressing the specific types of suffering, and that also may require validation studies. So, for example, in Vietnam, we're just completing a validation study of a Vietnamese version of the palliative outcome scale, which is one of the very brief but comprehensive measurement tools, research tools, but that can also be a clinical tool developed by King's College London. There are various tools to assess symptoms, but they often need to be validated. So, for example, I know there's one tool to evaluate pain, and one of the questions is about how much pain is limiting function. And it says, the question is, would you be able to vacuum your house? Well, many countries people don't have vacuum cleaners, so the tool needs to be adapted for local context. And thank you again for emphasizing culture. and the different ways that people communicate, wish to communicate, their different understandings of health and illness and death and afterlife. And I think these are very important research questions, and sometimes qualitative or social science research methods may be the best way to assess these kinds of questions. Well, I think we're approaching the end, and I apologize that we had some technical problems and we weren't able to get to some of the questions from participants, but I want to thank you all so much for this panel discussion. I learned a lot. I think we can learn a lot from each other. You are all pioneers doing extraordinary work in a field and creating new paths that others will be able to follow. So again, Professor Nizam, Dr. Ning Shahong, Dr. Pedro Perez Cruz, and Dr. Leda Yuang, thank you so much. And thank you to the Consortium of Universities for Global Health